give the floor to Michael Schlander on the topic of socio-economic impact of cancer and cancer treatment.
So thank you very much, and thank you for your interest. I have one chart only, that is this one, which I have to start with a correction, actually, because you should put the L after the SCH and not after the D, which might have an entirely different meaning, at least in my language. And certainly I don't want to put a Schande, a blame or whatever to the OECI and US audience. I have not prepared slides, not because of laziness, but rather because of a concern that I have in the last presentation. Never know how much time is left, and rushing through a whole set of data does not make really sense to an audience that cannot follow all the small print. And what would I have done? I would probably have repeated things that you can read in the Lancet publication to a large extent. So I trust you can read, you can review, and you will have your own opinion on that. I would like to emphasize a few points regarding the rationale as well as regarding next steps that we are planning. And as to the rationale, actually I would like to start with a confession here that you will not read in the papers, because these are things you don't publish. About 3 years ago or so, we had a discussion between NKI and my team at the DKFZ about potential opportunities to cooperate in the field. I think it was slightly more than 3 years back. And one of the areas that we identified was what we now call socio-economic impact of cancer. And as a health economist, you know, I always gave presentations and lectures. Look, we have the societal perspective, which we theoretically prefer, the theoretical high ground. We have the payers' perspectives in various variants, which is more often used in the HTA context for reasons better or worse, depending on your perspective. And then, of course, we have the perspective of employers, and we have the perspective of patients, and then we continued with the traditional stuff. So what it was is lip service. The patient perspective existed in theory, but not in practice. And this is just an aside, because I had the personal experience that my wife passed away because of colorectal cancer a couple of years back. And when she got the diagnosis, it was already an advanced metastatic disease. And I was, apart from all the other things that don't play a role here in our context, I was honestly surprised by the amount of financial resources this required. All of a sudden, co-pays. She lost her income, and we have 2 children, one of them at school age, so it was immediately clear this is more than financial toxicity. We have to deal with something that is much broader when we look at it from the patient perspective and the family perspective, the perspective of relatives. And that triggered my interest to do something that is not really fancy within the realm of economics. In economics, you get a professorship for doing fancy econometric analyses, methodologically elegant stuff. For example, the study on DRG efficiency increases. This is something, doesn't matter whether it's valid or not, you get a professorship for that in that particular case. I don't want to drop the name, and it doesn't play a role. My point here is what we want to do, and that is important to our project. We should work on projects that are, number one, policy relevant, and not of theoretical elegance, but in an ivory tower. And secondly, as scientists, whether or not we have a personal motivation in the background, we should try hard to do it as neutrally as possible. And that's another reason, because financial toxicity is not only a narrow term, looking at the effect of treatment only and potentially co-payments only. At least if you look at the origin of the term, it really meant like that in the very beginning. But we should also not use that term that is part of the conclusions that we reached in the task force because of reasons for the reasons of scientific neutrality. We should not start with a pre-assumption what we will find, but rather try to be as objective and as differentiated as possible. And socioeconomic impact can, and I'm not saying it will be, and I'm not even saying it will be dominantly so, but it can even have positive effects on patients. Because you can have also psychological components like increasing family cohesion and friends that help you. So there are also positive experiences which we should not neglect and rule out to consider right from the start. So it's a very complex picture that we are dealing with, and we tried in that task force that we decided to set up within the context of the working group Health Economics of Valeska and Wim. We decided to really start out with a neutral approach and start with an inventory of the scientific evidence that is available on something that is usually still called financial toxicity, that is increasingly being realized to be not just a US phenomenon, where the system, of course, is different and we have a completely different context, but rather is something that can be extremely relevant to patients within comprehensive social systems, also in the European context. And then, of course, the question arises, who is affected by it? So we need to be differentiating. And the first case is, well, how do we measure it? What are we talking about? So what we came up after 2 years of work within that task force is we came up with consensus recommendations on a couple of points. First of all, how do we define socioeconomic impact? And how can we link the concept to established concepts of other disciplines, including but not only health economics? So it should be related to the ways we deal with cost in health economics, even though the patient perspective will induce certain differences. But we should not start out inventing something new, and I will get back why this is important. The other thing is, we are talking about patient-reported outcomes, so we should establish links to the established principles of PRO research and not start to invent something new. So part of what we developed is, because we observed a huge heterogeneity of the existing publications, which makes them very difficult to compare, up to the point that some of the existing research is actually useless for policy purposes simply because of ad hoc definitions being used, ad hoc questionnaires being used, or simple questions just added on top of a study in a pick-it-pack manner. We felt we should go back and try to define standards. And the first thing was to develop a conceptual framework, which we did. In the course of the project, we had 12 meetings over a period of 2 years' time, actually. After half of the time, we had the outline of the conceptual framework, which we refined afterwards. And that was building on a best fit framework synthesis of no less than 18 different frameworks that had already been proposed and were around at the time, but we felt a need for consistent terminology derived from that and hopefully more consistent use of terms and measures in the future to make research more effective, more efficient, and comparable in particular across different settings and different contexts. So in a nutshell, what we wound up with up to this point you could, in order to make it memorable, say there were 25 people in the task force and there are 25 authors. They represent 25 different institutions and they came up with 25 recommendations. Some beyond the framework and definitions, but rather also touching on research priorities. And this is within the remaining few minutes that I've got, what I would like to point to one of the important priorities that we are working on in different contexts. That is, of course, once you have a conceptual framework and definitions, the next step is you need to have a look at what are the instruments that you use to measure that construct. So there are further publications beyond the Lancet publication in different stages of development, one being from the SEC trial, from the NKI and the OECI group, but others that will use the SEC data for instrument validation, as well as an input for further instrument development. We have an instrument review, a systematic review close to submission, and we will publish a paper that internally has been called the rationale Chanel paper that is giving the the reasoning behind the concept development and the conceptual links to established theories. There's also a taxonomy review underway from Rachel, actually, who is here with us, who was also, for very good reasons, the last author of the Lancet publication. Very, very helpful member of my team. And I have, because of limited time, I think I should now try to conclude, and I can only conclude by giving credit to these 25 people. I cannot give the names of all of them. It's far beyond DKFZ and NKI teams. As I said, there are 25 institutions represented on that task force. We will move on with a focus on instrument validation, instrument development as a next step. We will reach out to other groups who are working on the same topic, trying to come to a more integrative approach instead of, separating the field even further. And the final thing is, like Valeska did before, like Wim did before, like Nora and Sabine did before, also an invitation to join. Just let either Valeska, Wim, or me know that you are interested in joining the task force. We are committed to an inclusive, to an open approach, and we are happy for everybody who wants to contribute to the next steps in that field, which we believe is one that is of eminent policy relevance and still neglected to an extent that does harm to at least a portion of our patients. Not everybody necessarily, but some patient groups are certainly hit hard, and this is something that we should provide robust data in an objective and neutral manner as much as possible as human beings, so that can be fed in to the further development of healthcare policies designed to provide care to cancer patients at the end of the day. So many thanks for your attention. I think I have also overrun my time budget a little bit, but I think we are still within the overall frame. Thank you for your attention.
Okay. Thank you very much. Are there questions for Michael on the topic or observations in terms of what are relevant trends or issues to be tackled? If not, thank you very much. We will be back with further developments in sessions in the coming years. And as said, if you would like to join the workforce, the task force or the working group, please feel free to approach us. There's still one remark on the OncoValue projects. We have presented one case study, but the project foresees in especially OECI members that are interested to take part in case studies, and there will also be some compensation for in terms of person months if you want to join working on those cases. So be aware that later on in the coming year there will be a call, probably through the working group, but maybe also through other channels, for OCI institutions to take part in case studies in the OncoValue project. So that is still a remark that may be useful. If there are no other remarks or second thoughts or questions for which I would like to give the floor, I don't see them. So, and then I would thank you very much for your interest. I would thank the speakers for their efforts and wish you a nice continuation of the annual days. Thank you.